Everyone,
And
everyone can see my screen, right? Intro to EMDR therapy.
not, I'm seeing everybody, but not.
Oh, I didn't share here. Now everyone should be able to see my screen.
Okay. So let me just do a little intro. On behalf of West Coast Mindfulness Institute, our network, um, really happy to have Jason present. He's a wonderful presenter and has done this a lot, actually, with um, EFT and EMDR. And I will also say that Jason works with us in the EBMC domain, supervising clinicians at the San Diego Mindfulness Center. And we have his father here. The one tidbit I know about Jason is he likes to let his car do the driving. So with that introduction, he let me drive his car, but he said, "Don't touch anything. It's gonna do it all by itself," and it did. It was pretty crazy.
That is so funny.
My introduction to it. So I'll hand it over to Jason, and thanks for everyone coming. And yeah,
Yeah, awesome. I've also the brain is really good at automating, things that we do a lot. So I think a lot of my EMDR work can become a little bit automated, like the self-driving cars. But let me see if I can give you guys an introduction. So everyone can feel like they know a little bit about EMDR. It's pretty much as old as I am. It was kind of birth was in 88, 89 when Shapiro was doing her dissertation. Francine Shapiro is the creator of EMDR. It used to be called just eye movement desensitization, just EMD. Until like for the first 2 years, and that's just about lowering trauma symptoms, intrusions, nightmares, hypervigilance. It became as just like a symptom. It started as kind of like a symptom reduction, but then it kind of grew into a very comprehensive treatment approach. Um, it achieved really good results in the research in the late 80s and early 90s, even with 6 month follow-ups. And we're talking about one or two sessions in around 40 minutes. The original populations that EMDR was studied on in the late 80s and the early 90s is veterans and women that had been raped or assaulted. And both populations got almost crazy good results. If you look at the initial papers from the late 80s and the early 90s, so now it's much, much more than just symptom relief. It's kind of an integrated information processing paradigm and full comprehensive treatment for most clinical issues that clients bring in. I'm going to talk about that a little bit later. It's all about evoking positive affect, so promoting mental health and building positive memory networks, not just loosening or lowering the intensity of traumatic memory networks. And it's been about just as old as me, 35 plus years of really solid research projects, over 20 randomized controlled trials, which I think even if you don't know how that works, it's the gold standard in psychotherapy research. And it's now, there's if you go onto Google Scholar, you could probably find an EMDR paper for any topic, parenting, um, pedophilia, addiction, you name it. There's probably an EMDR paper on it. Hundreds of papers. I think it's like a few hundred papers are published on EMDR every year. Um, and it's all about reprocessing the memories that are underlying the present dysfunction. So like if I compare it to like CBT, it's all about optimizing and changing thought patterns and behavior with EMDR. So like in for example, let's just say cognitive therapy, the locus of pathology, if you will, are kind of like negative, unproductive, counterproductive, maladaptive thoughts, right? But in EMDR, it's about memory networks. So we can think of these disturbing memories as like wounds, like bullet wounds, massive cuts, broken bones. If we compare the psychological pathology to physical or even injuries, maybe injuries is a better term than pathology. So it's all about any mental health problem, even ones that are like known to be intractable, such as borderline, even antisocial. We see positive research that EMDR can help by reprocessing the memories underlying the present dysfunction. Just like we would go into a computer, like let's say that, our minds are like our minds, brains, and bodies are like computers, and these traumatic memories are stored as if they're flashing red on the desktop, taking up memory and interrupting everything that you're doing on your computer. And then EMDR can help open up that memory, restructure it, and reformat it to put it back in the 1990 folder or the 1998 folder or the 2010 folder so that the person can function much more adaptively with higher mental health markers, connection, better sleep, better functioning in work and school, and more presence in their relationships and things like that. So memories are the locus of pathology, and we're optimizing memory storage. I'm going to talk more about that soon. It's kind of birth is also a little bit silly, and it was attacked from about 1990 to around the early 2000s until the EMDR research was so positive that it kind of silenced all the critics. Like you got Bessel van der Kolk on board and a lot of other heavy hitters. So Shapiro was walking in a Palo Alto park in the late 80s. I think it was 85 or 86, which is I think a lot of you live near there. But she was noticing when she was walking that she was moving her eyes back and forth. A lot of people do that naturally. Like when you ask someone a complicated question or you ask them about like, if they want to meet next Saturday or whatever, they often go like this with their eyes. They just move their eyes back and forth like spontaneously, just like an REM sleep. And Shapiro noticed that when she was moving her eyes back and forth, the disturbing memories or things that she was thinking about kind of went down. So again, clinical pathology is how memories are stored. That's one of the most basic ideas of EMDR. And the desired clinical change is effective psychological processing of these memories and incorporating them into adaptive, true, positive memory networks. I'll talk more about that soon. In basic terms, it's helping clients convert negative experiences into adaptive, life-affirming, positive learning experiences. This could be anything. Trauma is about how the memory is stored, registered, the body's response to it, not the event, right? So it's not about like it has to be a car accident or it has to be a rape or an assault. It could be anything. How it's stored in the body, a difficult job interview, a difficult interaction with a neighbor, and we're converting the storage of those memories. So here's how we would like if I was talking about EMDR to someone like in an elevator, first floor to fifth floor. This is kind of like the little script, and you don't have to memorize it. It's in the EMDR manual if you decide to get trained. When a disturbing event occurs, it can get locked in the brain with the original picture, sounds, images, thoughts, feelings, and body sensations. I actually picture is enough. I don't need to repeat images. EMDR procedures stimulate the information and allow the brain to reprocess the experience. That may be what is happening in REM sleep. It seems to mimic the REM sleep. I don't know if you've ever had maybe you could raise your hand if you've had the experience of being kind of upset about something, anything, a client, a difficult interaction with your partner, your child, anything. And then you wake up the next morning, and it's like, oh, that isn't that big of a deal. All you have to do is kind of like talk to that person, send an email. So a lot of that healing kind of sleep on it effect that happens during REM sleep, it seems like EMDR is trying to kind of simulate that effect, even though we're still learning about how it works. We know that it works extremely well, but we're still learning how it works. 35 years isn't that much of time, and that's only a few years after PTSD even existed in the DSM. P PTSD got introduced into the DSM in 1980, so it's only about 45 years old. Um, I interrupted my little speech here. So EMDR stimulates the information that's stored, negative beliefs, body sensations, images, sounds, even impulses, urges that are connected to the memory. And the eye movements, or now we know tones, tactile, can have a similar effect, even though eye movements are shown to be superior in this moment in time. Help reprocess the disturbing memories and experiences, and it's the client's brain, body, and mind that's in control. You're the one in control. You can look at that little script later. I can send Itai the slides if you'd like. So here are the components of memories that we're trying to reformat, restructure, just like we would in a computer file or an app on your phone. The sensory input, images. So when a traumatic event is kind of disturbing, the image like of the guy that assaulted me, or the mean job interviewer, or like the like scary car accident. There's images, there's thoughts. I'm not safe. I'm not good enough. I'm not in control. Also core beliefs. Similarly, I'm inadequate. I'm not lovable. I'm all alone, even if that person has good relationships. Emotions, fear, sadness, shame, guilt, terror, rage, right? body sensations, tension in your chest, in your stomach, in your neck, right? So EMDR is all about stimulating the storage of the memory so that it can be reshuffled, reformatted in the brain, mind, body. Um, Slow me down if I'm going too fast here. I had some coffee and this is like just such kind of repeat information for me that I'm probably I feel like I'm going too fast if you're new to EMDR, so slow me down. Here's kind of a basic treatment plan for EMDR, like how it works. So, let's say, Daniel Linder comes in for therapy, right? Because he wants to work on whatever it is, anxiety. I'm just giving you guys an example. So first we would work on a past memory, of his father or mother talking down to him and like, punishing him for doing his chores poorly, right? And then memory two, it's all in the chronology of time, past, present, future. So memory two could be middle school and he was teased because he liked a girl named Sarah, and then like Sarah's friend Rachel, like called him out in front of the class and everyone laughed, right? Memory three could be a college situation where, he failed an exam or whatever it is. Memory four could be a really dangerous car accident where he broke his leg, right? So we target all the memories in their order that are driving PTSD symptoms or any kind of mental health symptoms that we work on, confidence, relationship issues, insomnia. And then we target with EMDR present triggers that are, the insomnia in the present, arguments with spouse or partner, anxiety when, driving to work, whatever. We target those using EMDR. Then we also try to address future things. So how the person wants to respond when therapy is over, or when my joke is when clients feel really good about firing us. So the future templates in EMDR would be like, next time I have an argument with my spouse or we have a disagreement, I would respond differently from a place of mental health, groundedness, equanimity, instead of the trauma reaction of being automatically defensive, reactive. So it's all in the order of time. It's a really big thing in EMDR. We call it a three-prong protocol, which just refers to the three dimensions of time: past, present, future. We target things in their order, the same order that you would watch a show, right? You don't start a show on season five, you start it on season one. You don't watch a movie in the middle, starting in the middle, right? You watch it. So we're often trying to go back to childhood experiences because when we're children, we are fundamentally insecure. We depend on our caregivers. We don't have our own transport, our own knowledge, our own money. So we start our children's brains, bodies, minds are very vulnerable to trauma, because they're kind of they don't have all the brain development, language development, dependent on caregivers. So we're targeting things in their order. It's very typical. Like in the EMDR trainings that I facilitate in, the clinicians practice on each other. We start in groups of three. Like we have lecture in the morning, we have lunch, and then we have practice for about 2 to 3 hours, 2 to 4 hours actually, and they meet in groups of three. First, you have a clinician practicing EMDR on, one of their colleagues, usually getting a childhood memory that's the root of the disturbance. Like, for example, if I go back to Daniel Linder's example, just as a, for I guess like pedagogic purposes, the first time that he felt extreme anxiety could be, dealing with his mother. So we would go back to that childhood memory and we would stimulate the information, like I said, negative thoughts, beliefs, body sensations, images, sounds, impulses, and urges connected to the memory, and we would target them in their order. And that should already start to lower anxiety symptoms, for example. And then we would target, if it's still needed, present examples of how the anxiety shows up at work, partners in stores, with the waiter that overcharged you, with triggers around Gaza or politics, that whatever it is that triggers anxiety. So we would target things in their order. Does this make sense to people until I move
Mhm.
on? Thanks, Ryan. Um, so EMDR is all about every model has its kind of mechanism of change. And in EMDR, it's called the AIP, the Adaptive Information Processing. Our brains, bodies, minds are actually really good at turning kind of painful or uncomfortable or difficult experiences into learning experiences, right? Like you have maybe an uncomfortable interaction with a colleague, and then you learn, ooh, I should be more patient. I should have listened more. I can repair with that person. It'll build our relationship even stronger. So we tend to move towards adaptive thinking and processing with most things that happen to us. Believe it or not, around 75% of humans that go through traumatic events do not develop PTSD. Right? Why? Because our bodies know how to heal. We heal from flus and cuts and bruises and colds, right? Our body is usually pretty good, but when a traumatic event occurs, it blocks the body's natural healing. And EMDR is all about unblocking that natural healing. Just like a physical wound, like my body will heal from a cut, but if there's a big nail in my skin, it's not going to heal so well. We got to take out the nail first, right? Same with a splinter, a bullet. So EMDR is not what's healing the client, it's unblocking all of the traumatic material that's overwhelming the client system that changes them as a person. And it's helping them return to their resilience, adaptive, natural, natural way of being, right? This is how we heal. Humans move towards adaptive thinking, processing, acting, feeling, but trauma blocks it. So, as we would say, this accounts for the speed of clinical results in EMDR. A lot of the EMDR research is we get really positive results from 3 to 6 60-minute sessions. It's pretty. It could be short term, very very powerful. For those like EIP contracts or clients that can only pay for 4 to 10 sessions, or insurance companies that are only allocating or allowing 6 sessions. That could still be a lot. Um, EMDR was also influenced from Pavlov's. Raise your hand if you know about classical conditioning from Ivan Pavlov's. About 100 years ago, the dogs. Um, and Shapiro's PhD is in behavioral psychology, so you can feel the influences of almost any different camp of therapy. But just like the dogs were conditioned to salivate from the bell with no food present after 5 to 8 times, trauma conditions us in a similar way. It can make us avoid things, be very reactive, have a lot of core negative beliefs, feel tense body sensations when a song comes up that reminds them of the original traumatic event, right? So we're kind of reshuffling that conditioning. So from an EMDR perspective, we can think of PTSD or any mental health issue as an information processing disorder. Information is inadequately processed, ineffectually processed, and maladaptively processed. So we access that information in EMDR and we reformat it so that it's adaptive, with strength, with confidence, with calm, equanimity, instead of the traumatic material of reactivity, tension, negative beliefs, arguing, disconnection, addiction, insomnia. So when the IIT functions as usual, which it usually does for most people, um, it appropriately stores incoming information to use in the future, right? Like if you have a disagreement, you learn from it, you repair, and you become stronger. Just like, if you go to the gym, your muscles grow. But like we could think of PTSD, if I use the gym metaphor, as you worked out too hard and you tore the muscle. Severely. And EMDR is all about repairing that muscle tissue so that you can go back to the gym and lift even harder, and build muscle and not get injured. Again, if I use that metaphor. So when the Zoom thing is blocking my access to my slides. When the AIP, when our information processing is deluged with an overwhelming stressful experience, like a traumatic experience, it becomes blocked. And then problems develop from inadequately stored information when the AIP fails to do its job. And the disturbing information, negative beliefs, body sensations, emotions, sounds, impulses, urges get locked in the body. So the dysfunctional storage of memory happens because the brain, body, and mind are unable to access adaptive informations at the time it occurred. So overwhelming experiences become locked in the nervous system and the body, how they were originally stored. So it's like, even though, you can be 50 or 60 years old, these memories are often still stored through the eyes of your 5-year-old self or your 10-year-old self. Um, yeah, they could become literally frozen in time, just like, if I had a splinter, a big one stuck in my arm from when I was 5 years old, and I never got treatment for it, it would stay there. The wound is going to swell up, pus would build around it, and it can get worse. People say time heals all wounds, and it's one of those kind of adages that turns out to not be true with PTSD. I wouldn't have a job. A lot of you wouldn't, and we wouldn't get so much interest in EMDR, to where most EMDR therapists that are good are full and charging, decent rates. Um, Unprocessed memories become stored in the wrong form of memory. They become stored implicitly. Like the same way that you would learn how to drive, that you learn how to play the piano, they
Hmm.
could be stored like really trapped in the body somatically, right? Any good therapy needs to address the body. So when you do EMDR, we're helping the storage of memory to become from implicit and emotional or somatic, even motoric, to be stored into explicit, declarative, semantic, narrative. An example for me is I did some EMDR therapy when I was um, probably about 20 something in 2013, so probably about 24. And I was working on memories of being teased for having a lot of acne and for stuttering. And before I did EMDR, it was really hard for me to think of those memories. Whenever something popped into my mind that reminded me of high school, or when I drove by my old high school, it would give me like a little bit of panic and tension. I would feel alone and not good enough and rejected and like tension in my shoulders and chest. And after EMDR, like there's no activation anymore. There's no somatic, motoric, emotional, implicit activation. I just drive by and say, yeah, peers were mean, hurt people. I was strong and resilient for getting through it and still getting good grades and going to good school and building a good career. And I feel sad for those bullies because people that bully are hurt, and I feel like proud of my child self. That's after EMDR. Before EMDR, I wouldn't want to talk about it. I would kind of avoid it. I would think negatively about it and really bad about myself. So trauma is stored declaratively, and this contributes to a trauma sufferer's common experience of it feeling stuck, vacillating between hyper arousal and avoidance. Being overly triggered and reactive, or kind of shutting down, avoiding, going out and all the things that avoidance and numbness. So you're going back from being over aroused to under aroused. But then after EMDR treatment, you kind of go back to your normal baseline arousal or in your window of tolerance. Does everyone know what I mean by that term, window of tolerance? When you're pretty calm, grounded, present. When you're hyper aroused, you're too revved up. When you're hypo aroused, you're too shut down. So trauma, kind of leaves people between hyper arousal and hypo arousal. And after a successful EMDR, they can stay in their window of tolerance when they face triggers that are similar to the traumatic event. EMDR thus helps memories become stored declaratively by accessing and transforming them directly. And activating the AIP during EMDR, it turns out that the eye movements that we do during EMDR, which is why it's called EMDR, which I'll get to later, help the brain, body, and mind reformat the memory. Because I remember when I was at Davis and I took a course called Human Memory, and it was so funny because the professor was really forgetful. He missed a class one time, and it's like no wonder he studied human memory, but he was really big in that field. And one of the things that I learned from that course is that like when you have any event, for example, like what you ate for dinner 2 days ago, and you describe that event to a friend, the description of the memory replaces the actual memory. So when you think of that event again, you'll remember how you told it to your friend instead of what actually happened. And so in trauma, a lot of, it's so triggering to even talk about it that it gets stored and avoided, stored in a bad way. But then when you work on it in therapy through the eye movements, the calm and boring eye movements and the safety that the client feels with us through the therapeutic alliance replaces the disturbance. And the memory just kind of becomes boring and, like I said, explicit, declarative, semantic, and narrative instead of somatic, emotional, implicit, motoric. Just like you would heal from a cut, bruise, injury, COVID, flu. Our brains have, this is a little bit repetitive, but I want to drive this home. Our minds have a natural capacity to process what happens to us in a healthy, adaptive way. However, significant stressful experiences or traumatic events overwhelmed our brain's natural capacity, and then that information related to a stressful experience becomes maladaptively or ineffectually processed, and the initial perceptions of "I'm not good enough" and tension in your stomach and a crippling fear, all those get stored in the body like a splinter, a bullet wound. And then EMDR kind of accesses that memory and reformats it in the most painless way that we can think of. Maybe not better than, for example, PE, prolonged exposure, or TFCBT, trauma-focused CBT, but faster and usually better tolerated by clients. After a successful course of EMDR therapy, trauma survivors learn to approach situations with equanimity and flexibility. Flexibility is almost almost always associated with mental health, whereas trauma makes us rigid, yet with appropriate caution. This is consistent with activating the AIP, the integration of healed memories, of unhealed memories into the innate, larger, life-enhancing adaptive memory networks. Like, for example, Itai knows that he's confident, competent, worthy, a good clinician. But if he goes through, let's say, like a really hard session and his client is yelling at him, and if that memory becomes stored traumatically, all of a sudden he could start thinking that he's not a good therapist and he shouldn't do therapy and he cancels all the sessions. Then after EMDR, he targets that, maybe traumatic session and he goes back. His confidence and skills and resilience absorbs the disturbing memory of the hard session, and he goes back to his normal, strong self, and maybe even more resilient and more feelings of competence than he did before because he can get through a difficult session with a hard client or a really triggered client. The processing of a memory and this type of storage becomes pathological, not the event itself, right? So the pathology in EMDR is the dysfunctional storage of memory. And then we access that memory and we reformat it just like a doctor would with a cut or, like a massive, uh, broken bone injury, whatever it is, infection even. And then after EMDR, we get an adaptive resolution of the memory, much less emotional charge, if any, linked to positive memory adaptive networks and coherent personal narrative. Um, the traumatic gets kind of integrated into all the good things that the person knows about themselves, resilience, calm, connectedness, strength, all that, which most of us are. So EMDR in EMDR, trauma or all the pathology that clients bring to us, all the issues, are thought of as functions of dysfunctionally stored memory networks, and we heal and integrate those memory networks. That's probably one thing to remember about this talk since we forget a lot of most of you are probably going to remember about 30% of this talk, just because that's how human memory works. So that's one thing to really keep in mind. EMDR soothes the reactive sympathetic nervous system associated with traumatic experience, directly lowering physiological arousal. The eye movements in EMDR are very calming, they're very boring, and that boringness and calmness absorbs the emotional charge of the memory, which is usually the most disturbing. Now think of stuttering and acne like I don't feel anything, totally neutral. Whereas before, I would feel revved up, I'd feel my heart racing, I would feel embarrassed about talking about it because I would think that, all the audience would realize that I'm, not good enough and I'm a failure and I'm rejected and unworthy and all those things. But that's from the trauma memory networks that I already healed about 12 years ago. Um, so when a memory is processed in EMDR to completion, it informs but does not control the person. They're able to remember it, but it does not, but not experience the old sensations, emotions, and maladaptive self-concept in the present, such as I'm not good enough, or I'm not in control, or I'm not safe, or I'm unworthy, things like that. Abuse victims begin with EMDR with a negative self-concept, often like it was my fault or I deserved it, and then regarding the abuse, and then often end in EMDR with an affirmative sense of self-worth. And the opposite doesn't happen because the AIP gets activated in EMDR. And what is the AIP? Our brain, body, and mind's natural capacity to heal, which it usually does most of the time, just like we heal from cuts, bruises, and other issues. Something cool about our inside our mouth that I learned from my dentist is your mouth never, like the gums and tongue and the inside of the cheeks, they never scar. It's crazy. Like you could have massive injuries and cuts and they never scar. Inside the mouth, the saliva heals, and that's a good metaphor for EMDR. We could make really disturbing memories, make them neutral or even like positive learning experiences or indicators of strength, resilience, post-traumatic growth, things like that. So all we're doing in EMDR is activating the AIP when the person has the components of the disturbing memories up. I'm not good enough, tension in chest, negative, intense memory, intense vivid images from the memories. People that are really, traumatized from memory, the images from the memory often feel extremely vivid, intense, crippling. They show up in nightmares and that they pop up, when the person sees the same car that the abuser was in, or the same street where it happened, or the same shirt that the abuser was wearing. And then afterwards, everything kind of neutralizes. So because clients get relaxed easy from the eye movements, they just won't feel the agitation from the trauma because the relaxation inhibits the arousal. Raise your hand if anyone has heard of Joseph Wolpe's principle of reciprocal inhibition from the 1950s, right?
Hmm.
Shapiro's capitalizing on this because the when you pull up the disturbance from the memory and you pair it with a very boring stimulus like the eye movements in the context of a safe therapeutic alliance, um, the relaxation and the calm absorb because the client can't feel calm and agitated at the same time. So the calm, boring eye movements kind of absorb the disturbance of the memory. Um, and the eye movements are supposed to be fast, so they interfere with the client's natural avoidance of a disturbing memory, but slow enough to where it distracts the clients from their internal experience. This BLS is really common actually in everything that we do. Like good songs make us move back and forth, and it has that natural BLS that is part of calming clients' eye movements, right? We naturally do eye movements during REM sleep, usually 2 hours every night. If you have a good night's sleep, maybe even two and a half. When we are stressed, we often go for a walk that has BLS, naturally the eye movements back and forth. If you have a baby and your baby's crying a lot, parents often rock the baby back and forth. So there's BLS in the natural world and even in indigenous healing practices, there's often this back and forth drumming. So there's BLS everywhere, and Shapiro shouldn't get all the credit for it since she's using principles and healing rituals from thousands and hundreds of years ago, even from indigenous cultures. So the BLS can also cause an orienting response. So in the therapy session, there's no indicators of peril, there's no danger, there's decreased arousal there, and then there's positive physical sensations because the eye movements and the BLS, if you get buzzers back and forth or audio, there's a lot of ways to do it, but eye movements are usually very, very important. But they just neutralize the memory quickly and easily, much beyond talk therapy. Um, so there's increasing evidence that BLS is indeed important for the curative aspect for about 30 years of that.
Wait, I want to ask you, what does BLS stand for? What is that?
Bilateral stimulation, thanks for asking. It's the back and forth eye movements, but now they can be done, for people that have like, they get dry eyes easily. The eye movements are actually a very natural movement for our eyes because, like I said, we do them for 1 to 3 hours every night during REM sleep. Um, and our eyes are not looking at anything because our eyes are closed and we're sleeping. So clearly, the eye movements are very important to help our brains process information, move information from short-term into long-term storage, um, harness important information from the day, discard non-important information from the day. Um, so yeah,
Jason, I have a question also.
please.
Um, when you're with a client and you're doing the eye movement, are they eyes open or closed?
Closed, opened is ideal, but some clients have difficulty with open eyes because they can't access the memory. So you can do closed BLS, but it's a little bit hard to do it when your eyes are closed. But usually eyes open. Eyes open usually helps too because if our clients' eyes are closed, most of the time, this is not for every client, but it they can get sucked into the disturbance more easily and lose that sense of presence in the room. So eyes open also helps the clinician know that they're present and not dissociated. And
Okay.
EMDR works best when half of the client's attention is in the present room with you in the therapy session, and the other half of them is in the memory network so that they can re-experience, for example, the 5-year-old memory through the eyes of their 40-year-old self and not re-experience it through the eyes of a child with fear and I'm not good enough and tension in their chest and scary images of mom's yelling face or whatever it is. So I kind of answered Daniel's question here. The EM part of EMDR acronym stands for eye movement. Probably should have had this slide earlier. Originally believed to catalyze, activate the AIP's optimal functioning, which EMDR therapists apply to help clients process traumatic memories so that they become declaratively stored instead of implicitly, somatically, and motorically stored. The eye movements refer to the original form of BLS, where the clinician moves their hand back and forth. See, I should have had this slide earlier. They could be back and forth vertically horizontally is most common, but if the client is kind of stuck, the clinician can do diagonal. They can even do vertical. And sometimes I have a light bar in my office. Sometimes it just helps change the color from yellow to red to pink to purple. to kind of help the brain have a different experience of the memory and catalyze AIP. Many clinicians use a light bar, but it's not necessary. You can do eye movements from one corner of the office to the other, and if it's on Zoom, from one area of their room to the other. But that could be a little bit tricky, like if the client gets distracted by, a window or cars passing by or whatever it is. As EMDR developed, practicing clinicians realized that other forms of BLS, such as hand taps, audio tones, work just as well, even some better than eye movements for certain clients, but research would still suggest eye movements are superior. I have a LinkedIn article, if you find me on LinkedIn, that covers about 15 things that make eye movements really important, such as de decreasing vividness of the memory and also improving memory recall so that the information comes up from the memory and makes it easier to be reshuffled, scrambled, and reformatted. If eye movements irritate eyes, some people have medical conditions, blindness, so that they make the eye movements hard. So still, if Shapiro could redo it, she would just call it RP, RT, reprocessing therapy. But the EMDR acronym had already been present in so many books and articles that she had to preserve it for its historical context, not its functional context. It's really just reprocessing therapy, but the EMD, is already there. So um, later, Francine Shapiro regretted eye movement is built into the therapy's label, and she would have called it reprocessing therapy, just iterating that point. Um, yeah, I already explained that part, that last bullet point. From an EMDR perspective, evoking to consciousness a disturbing memory in tandem with therapist applied rhythmic BLS helps activate AIP, which then helps the memory resolve, heal, decrease in reactivity, disturbance, and have the person realize they're naturally, good enough, competent, instead of I'm not good enough, I'm not safe, whatever the beliefs are from the disturbing memory. Just like during REM sleep and deep sleep stages of deep sleep also, I think, is connected to the eye movements, but I'm not a sleep doctor. It does, though, help from short-term into long-term memory consolidation, re-experiencing the memory from the calmness and the BLS in the therapy session, not the original encoding of it. I already talked about natural uses of BLS. Sometimes I get so excited with this talk that I say things that are coming in a slide later. But everyone does BLS. Maybe like, people that are fidgety, our especially our teenage clients, they often do things like this. They're tapping on the chair, armrests, and they're tapping their feet back and forth. I used to play drums, and there was a lot of back and forth, everything like with your feet back and forth from the hi-hat to the bass drum to the snare to the different. So many things. For those of you that like dancing, like I said, there's natural BLS in so many things that we do. REM, sleep, walking, music, calming a crying baby. Although EMDR originated with only eye movements, a number of studies show that BLS facilitates desensitization when clients act as disturbing. Remember, this part's kind of repetitive. Eye movement decreases physiological arousal on skin conductance and lowers vividness of the memories, the intensity, and the emotionality. There's also some interesting research about how, like, before EMDR, if you have your client think of the disturbing memory, their right hemisphere will be more activated, like on an MRI. And the right hemisphere, there's a lot, it's a lot more complicated than this, but we can think of the right hemisphere as the experiencing part of our brain. So when the client thinks of the memory, they could just experience the negative beliefs and the intense body sensations and the feelings of fear and sadness and guilt and shame, experiencing it only. And then when they do EMDR after, and you have the client think of the memory with an MRI, their left hemisphere would now be activated, which is just stories, narrating facts, declarative, semantic, narrative, stored in neutralizing language instead of intense experiencing. Does that make sense to everyone?
Mm.
Resulting disturbing memories and their emotional features must be processed across the brain's hemisphere. And that's actually part of why we do BLS, because it helps our hemispheres communicate, whereas traumatic memories can be stored in kind of blocked off from all the adaptive, healthy, things that we know about ourselves. Mounting evidence in the EMDR shows that effective in through effective treatment, brain hemispheres become activated, hemispherically transferring information from somatic motoric into declarative narrative, just language, like just like I think of the stuttering memories with no emotional activation, no negative images of peers being mean and acne on my face, and just I think of that teenager as very resilient and one of my heroes, now after EMDR. Before, I wouldn't even mention it in a presentation. Although EMDR originated with only eye movements and memory traces of disturbing memories, Oh, I already talked about this one. That's the same one. Cool. Is that wait? I think yeah, I could present more information, but I thought that that would already be like too many slides and just I can keep going and just talking about it in more detail, but does anybody have any questions or slow me down because I'm all hopped up on coffee and yeah, Itai,
Um, so maybe if people have questions, they can also just say who they are and a little
please,
bit about what they're doing in their practice. And so
please
I'll
do.
just start with that. So I'm Itai and director of EBMC, but also in private practice, working with couples and individuals and families and seemingly more and more complex cases. I don't know if that's because I'm been licensed for a long time or it's just the way of the world. But I wanted to ask Jason, people talk about um, so bilateral stimulation in other ways besides the eyes, right? And you were talking about that babies and dancing. Can you talk about tapping and other ways that, yeah, how does that, is that a part of EMDR? Is that just like health and wellness? Because nowadays there's more and more healthy ways that we all are learning how to take care of ourselves and even going for a walk and tapping,
Yeah, or
things like
even
that.
just the steps from the walk also have natural BLS, even if you're not doing anything. The A lot of clients do tapping during EMDR. I find though that like, it's just easier for clients to be relaxed and passively receive the buzzing instead of having to do this also. But having this also can help. I went to the EMDR conference a few weeks ago, and it was a big theme. They call it taxing working memory. So a lot of clinicians now are getting better results, especially in EMDR Europe. They're receiving eye movements, like I said, but they're also tapping twice on this hand, then once on this hand, then twice on this hand, then once on this hand. Even there was a video of an EMDR trainer having the client spell out the abuser's name during the eye movements. So they were, during the eye movements, they were doing CHRIS. Like the more that we tax working memory, it looks like EMDR could even work faster. So there's this trend called EMDR 2.0 that's been around for about 15 years. I don't like it because they seem to like speed through and kind of not do comprehensive like standard protocol how EMDR is meant to be do, but they're getting really good results. So to answer your question, taxing working memory seems to be helpful. At the EMDR conference, there was probably 6 to 10 booths about different EMDR companies launching apps and ways of like that clients can self-soothe and so
Hmm.
there's a lot of natural BLS in the world. I wouldn't though recommend that clients try to target a memory alone. Like this is why we have jobs because trauma is healed relationally, and trauma happens usually relationally and it's healed relationally as well. And trauma isolates its victims, and connection heals. The worst part of every trauma, usually is a sense of aloneness, and the reason that we have jobs in EMDR just can't be, we give clients videos and techniques and they do it themselves is because having that strong therapeutic alliance helps clients heal quicker. So I'm probably over answering your question, but taxing working memory is important. There's a lot of ways to do it in EMDR sessions. The eye movements seem to be extremely important at really catalyzing AIP, but there's so many ways to do it in a natural way, like the gym. You're doing bicep curl. You're doing this arm and then that arm. Running, you're doing this step and then that step. The elliptical has the back and forth arm bars. Like it's just there's so many ways that we can get BLS in our natural world, and we do it naturally without even thinking about it. And it does seem to help calm us down, catalyze our AIP, but not in a way that can replace EMDR therapy so far that we know. Does that answer your question, Itai?
Yes, for sure.
Hmm. Um, what else does anyone have? It looks like we still have about, 5 to 10 minutes. I could describe a little bit like what m more specific details of what a clinician would do in a therapy session and the 8 phases of EMDR, but that may be a little bit too specific. No one has any other questions.
No, I have something. I have
Oh,
something I
you
can
do have
ask.
something, please.
Okay, I want to just say I'm Jason's dad. I'm Daniel, and I've been a relationship therapist for maybe 4 decades now doing this work. And a lot of I think all my work is really based on the premise that the cause is the cure when it comes to relationships. So dysfunctional, non-nourishing relationships are the source of the problems that bring people into therapy. And when you're able to impact how they do relationships and to in a way that they could turn their relationships, make them more nourishing, the problems dissipate, and it's all based on your problems are as big as your relationships, or as they are dysfunctional. So
Hmm.
that's what I do. But the question that I wanted to ask you, Jason, is that I'm wanting to get clear on EMDR as a technique for therapists to use. Now, what I'm unclear about is when you do EMDR, is it usually like a short-term, target-focused, trauma-oriented process that you take people through a certain number of sessions to deal with that problem, and then you're done with the therapy? Or is it something that you incorporate into the larger relationship alliance, the therapeutic alliance that you have? And um, if that's the case, what do you do before the EMDR, and what do you do after the EMDR if that therapeutic alliance continues? So I'm not. So is so okay. So did you get my question?
Yeah, like you're asking if it's kind of just a technique that I do, through with clients quickly, or I kind of it gets absorbed into like a more comprehensive therapeutic relationship and alliance that kind of addresses all of the everything that the client wants to address. And it's kind of both. Like ideally, I prefer to see as many clients as possible with the least number of sessions possible. And I like, EMDR tends to work quickly, and therapy can obviously be, a big cost for clients. So probably the average number of sessions that I would have with the typical client would probably be 6 to 15, maybe 6 to 20 that are 90-minute sessions. I usually do, but they can be 1 hour, they can be 2 hours. I'm very variable on my time and length of sessions. I think most clinicians do 50 or minutes or 1 hour, but I let clients choose the length that we find is best for their healing. But it's kind of both. It started as a technique, but now it's really a comprehensive therapy with eight phases, and there's a lot of alliance building and preparation. We could think of EMDR as an emotional surgery. So, phase one, we're doing like any therapy, history gathering, rapport building, treatment planning, right? Then we would do preparation. So if EMDR is an emotional surgery, and to fix that information processing disorder, the dysfunctional storage of memories, it helps to prepare the body, warming up, putting on the Novocaine if it's, dental surgery, which, is helping the client access positive states, calm, confidence, and that could be, there's so many ways to do that, mindfulness techniques and positive visualization. So it's kind of both to answer Daniel's question. I could keep going explaining the phase, but it may be probably an over answer, and I want to make sure that I can actually come back to the answer if I don't know if Ryan, Anita, Daniel, or has anything else. But did that answer your question, Daniel?
Yeah, yeah.
Linder?
Another question that I have from that is that you mentioned that the process and the quality of the EMDR, um, the way you do the EMDR presumes that there is a strong therapeutic alliance. Like you were saying, well, the EMDR is going to have much more impact in
Mm,
the context of the therapeutic alliance. But it sounds like you're
definitely.
assuming that you automatically have a therapeutic alliance, and in your in your description of the steps of EMDR, there's nothing there about developing a therapeutic alliance. It's like you.
There's a lot about it. It has to having a good therapeutic alliance is a prerequisite. It's like if you're gonna eat food, you need to have arms, you need to have fork and plate and knife and food. Like therapeutic alliance is essential for EMDR to work well. One of my like kind of guidelines that I tell clinicians is attunement to your client and building a very solid therapeutic alliance is more important than following the protocols, procedures of EMDR. Attunement before being an EMDR therapist and my motto, that goes to also with parenting and connection before correction, right? We really need to connect to our clients to build a strong therapeutic alliance. I guess to answer my dad's point, an hour or 50 minutes is, not enough to cover that part. But I guess I'm such a good therapist that I don't even need to cover it. I'm kidding. I'm kidding. But a therapy alliance is very important, and EMDR will probably fail without it. So that but phase one of EMDR is alliance building, rapport building, history gathering, treatment planning. So without a therapeutic alliance, we already see this in the common factors research. What are all clinicians doing well across models? A strong therapeutic alliance is vital, responsible for 30 to 50% of the therapeutic outcome. So um, modality seems to be responsible for only about 20 to 40% of the success in therapy. So obviously Daniel's point is very important. Um, Anita, thanks for the presentation. Very informative. I need to leave another point. Thanks, Anita, for joining, and thanks for your message. Does anybody I can go back to Daniel. Does Daniel Wright or Ryan, does anyone have anything else? Because I want to make sure that I can get to anyone's questions before we, have just a few minutes left. But then I could hear from, I think Itai was going to say something, and then Daniel. I'm all set. Thank you, Daniel Wright. And Ryan, you're good, looks like. And Eve, you're okay. You don't have any questions. Otherwise, we can go back to Daniel and Daniel Linder and Itai.
I will say, well, let me do a little bit of closing, and I know we could keep talking too, but um, this has been super informative for me, and even just like this basic level because of the ways it taps into understanding trauma
Mhm.
and all the other approaches to trauma and the relationship being so critical, however it's done. And I like the ways that, in a way, this could go faster. Um, but I want to plug next month for a sec because Daniel Wright is going to present. So
Awesome.
he'll be presenting mental health and academics, and Daniel comes from the fusion schools. There he is. So I
Awesome.
knew we could pull him on and get him to turn his camera on if I start talking about him. Um, but so we really look forward to your talk and connecting with us next month in November.
Yeah, I'm looking
Great.
forward to it. It'll be a unique presentation. We work a lot with mental health care professionals. It'll be a great presentation for folks who are interested in the kind of crossover for adolescents, especially between academics and the mental health care world. And at Fusion, those two things come together quite seamlessly and frequently. So I'm looking forward to presenting to anybody who wants to come to something a little bit different for this particular forum. So thank you for that opportunity.
Yeah, for sure.
That is November what day and at 9 a.m.
9 a.m. I believe it's the 14th,
Oh,
second
cool.
Friday.
Oh,
Yes.
nice. Okay, cool.
So,
Great.
yeah.
Um, Itai, can I ask the group one more thing before we leave, or did you
Yeah,
want to do more plug?
please.
If anyone wants to share just like one thing that they learned about EMDR that they didn't know, or that like excites them, or that surprised them, it could be just a word, a phrase, a sentence. But does anyone want to share like what you guys are taking away? Like, and we could be very brief because we have to wrap up here in a minute or two.
I'll
Um,
share briefly that
oh, thank you.
I heard you say that it can be life altering for people, and I think that's great. I have clients who are definitely dealing with trauma, and parents are seeking alternatives to medication. So that's always good to hear.
Mm. Thanks so much, Eve. Appreciate that. Maybe we got time for one or two more, and then we gotta end at 10 a.m. at the latest.
Yeah, Jason, you inspired me to do a little bit of research in the background while you were presenting. And I think the thing that I'm taking away from this is just how much research there is behind this particular methodology. It's so incredibly backed by research and studies. And I was comparing it to some other methodologies that I've heard of in the therapeutic field, and it is definitely way up there as far as just the kind of proof of concept and how long it's been around. So that was
Yeah, I
interesting.
mean, Shapiro just being a female in the late 80s and 90s, she really had to have science behind her or she'd be laughed at. And even with the science, she was laughed at for about 15 years. So she just had to be crazy, methodological and research based. EMDR also has a strong mindfulness element, and Shapiro was the meditator. But in the late 80s and 90s, mindfulness was not cool back then. It became cool probably in like 2010. Um, but that actually worked in our favor, right? Because a good model needs really solid research, at least to grow. So thanks, Daniel. We have to wrap up, but if you guys have anything else, email me, text me, stay in touch. What did Daniel say? I'm still trying to convince the kids that it's cool. There's a trainer that does EMDR with their dog and with their children briefly. With children, it could work so fast because they have like simple memory network. They don't have 10 years. They don't have 20, 30 years of trauma that's accumulated. So
Hmm.
I could go
Ryan,
on.
did you want to throw
Oh,
in?
did you want to throw in Ryan before we leave?
Don't need to hold us over. I just appreciated how I felt like I always viewed it as extremely rigid, but kind of hearing how you can really tailor it to the client and set them up more for success was a new introduction to me about EMDR. So thank you for that.
Yeah, things around like you could use EMDR just as like a separate technique, not to cancel out your current model, or you could let it kind of take over your whole practice, which I usually do. So this was fun. Thanks, Itai, for the invitation, and thanks Daniel Linder and Ryan. It was so it was really fun for me to do this, and thanks for your presence. And it was nice that we had a little small group. And yeah, thanks for the opportunity,
It was
Itai.
excellent, Jason. It's
Thank
really
you,
good.
Jason.
Oh, thank
Yeah,
you. Thank you
great
so much.
job.
Appreciate it.
See you later.
Thank you. See you
Bye
later.
bye.
Right.